This is chapter 62. We're going to be discussing problems with the pituitary and adrenal glands. Remember that your anterior pituitary gland controls your growth, any type of metabolic activity in your body, and the majority of your sexual development throughout the actions of the following hormones: your growth hormone, your TSH, which is your thyroid hormone, your ACTH, which has to do with your adrenocorticotropin hormone, FSH, that is the one that we females carry, your luteinizing hormone, which is your LH, your melanocyte stimulating hormone, MSH, that is the one that is responsible for how your skin is colored, and then of course prolactin. So disorders of the anterior pituitary gland, the primary pituitary dysfunction is when the problems are directly in the anterior pituitary gland itself. A secondary pituitary dysfunction is when, instead of being an anterior pituitary gland, it results from the hypothalamus, and those problems in the hypothalamus change how the pituitary functions. And as you would suspect, pituitary hypofunction is when one of those hormones that we named above is being under-secreted, it's not secreting enough, and of course hyperfunction is when it is being over-secreted. Hyperpituitarism is a deficiency of one or more of hormones, those that we again just named. The more common ones are your growth hormone or your gonadotropin deficiency. Specific things can cause this. Pituitary adenomas tend to be the more common. Surgeries, radiation therapy, traumas, hypothalamic tumors, infiltrated diseases, granulomas. Sheehan syndrome comes from postpartum hemorrhage. So just all you need to remember with this Sheehan syndrome is that you see it with postpartum hemorrhage. Your patient will become very hypotensive, and then realize that your thyroid gland, your pituitary gland enlarges during pregnancy, and then when the patient gets really hypotensive, they start to hemorrhage, cells start to die, then the pituitary gland starts to get ischemic and necrosis, and most of the time this condition happens like right after delivery. Kalman syndrome is just a deficiency of LH and FSH. Diagnosis for this is an MRI just to confirm the hormone deficiencies by blood work, and then treatment is to replace the hormones that are deficient. We just really discussed some of the causes of the hyperpituitarism. Of course, it's hormone over-secretion caused by pituitary tumors. It can also be caused by genetics, and then, of course, the pituitary adenoma tends to be the most common. And realize, too, that a pituitary adenoma is a benign tumor in the anterior pituitary. It can be classified by size, how invasive it is, how much tissue is involved, and then, of course, the hormone secreted. As this adenoma gets larger, it can compress brain tissue. Patient can have neurological changes, as well as a lot of endocrine problems. They can have things like visual disturbances, headaches, a lot of increased intracranial pressure. The most common type of pituitary adenoma is a prolactin pituitary adenoma, and it exhibits the secretion of the sex hormones in men and women, and then you get a production of breast milk. This can be in men and women. Women can also have amenorrhea, which is absence of their periods, and then, of course, infertility. So, again, we've already discussed the causes of hyperpituitarism. Basically, assessment-wise, we want to monitor the lab levels, also make sure we're giving back the hormones that these patients are missing. You want to make sure that you're assessing the patient's age, gender, any type of family history. These patients can have a lot of really high growth hormone levels, so they may have backache and joint pain from all of the bone changes. They can have headaches and changes in vision. You want to ask about changes in like hat, glove, ring, or shoe sizes because of the bone changes. They can have sexual function difficulty, decreased libido, painful intercourse, difficulty in becoming pregnant, and of course the same for men as far as impotence and decreased libido. In these particular patients, they only have one hormone produced in excess. And again, the most common hormones produced in excess with hyper are PRL, which is your prolactin, ACTH, and your growth hormone. Imaging are skull x-rays, CT scans, and MRI to detect soft tissue lesions. And again, some of the non-surgical management are drug therapy, radiation, and the gamma knife procedure. This is gigantism. It is the onset of growth hormone hypersecretion. So you're really hypersecreting all of this growth hormone, and this is before puberty. So as you can see from this picture, this particular gentleman, I believe, was either 7 or 8 feet tall. And so this shows the gigantism. This is acromegaly. It's the growth hormone hypersecretion after puberty. And what you see with acromegaly are you see changes in the bones. These are often caused by, again, pituitary adenomas, that benign tumor. These patients will have poor coordination, muscle weakness, atrophy, lethargy. They can have changes in their visual fields, emotional instability, hypertension, heart failure. How we're going to diagnose this is we're going to check their growth hormone from a blood test. We can do an MRI. Nursing management, we want to monitor the blood sugar levels. Again, we're going to be providing a lot of emotional support because this does change the way they look. Administer medications, specifically your dopamine antagonist. Monitor for side effects of radiation therapy that they've had in the past. The best surgery is the best approach to cure is called a hypophysectomy. And you'll want to monitor, of course, their neurological status and vision afterwards. And they'll have a little mustache dressing underneath the nose, and then instruct the client to report any type of a postnasal drip. And then, of course, not avoid coughing and sneezing and then blowing the nose, because they do go in through the nose to help fix that. And this is just the surgical management. This is the hypophysectomy, where they go in through the nose so they can clip that pituitary gland. And here are your postoperative care, neurological response, postnasal drip, elevate the head of the bed, assess any type of nasal drainage, avoid coughing, assess meningitis, hormone replacement, avoid bending and straining the stool because it can cause intracranial bleeding. Avoid toothbrushing, assess for numbness in the area of the incision. They may have a decrease in some smell, and they will be on vasopressin. Now let's switch gears and talk about diabetes insipidus. When you think about diabetes insipidus, think about the term insipidus, like the Sipsey River. It's a water metabolism problem. It's caused by your antidiuretic hormone, either a deficiency or an inability of the kidneys to respond to it. Something's happened with the kidneys. That ADH is there, but the kidneys can't pick it up and use it. So you have nephrogenic, primary, secondary, and drug-related. Your nephrogenic is just related, is drug-related. The primary DI is caused by some damage in the hypothalamus or the posterior pituitary gland, and then the ADH is not produced or released like it's supposed to. The secondary DI is occurs most often, and it results from tumors in or near the hypothalamus. or the pituitary gland. You can have, it can also be caused from head trauma, infectious processes, brain surgery, or metastatic tumors. And then, of course, your drug-related is usually related to drugs like lithium, declamycin, and those two drugs just interfere with the response of the kidneys to your ADH. So I left you this pretty little picture here. Diabetes insipidus, you have a large amount of urine, up to 20 liters of urine a day. You can have histories of a head injury, pituitary tumors, a craniotomy. The treatment for diabetes insipidus is vasopressin and ADAP. You have a low specific gravity, which generally is less than 1.005. You have a low osmolarity, hypovolemia, which means these patients, this is a emergency, these patients may be going into shock. You have increased thirst, tachycardic, and a decreased blood pressure. So what is our nursing care going to be for this patient? We're going to monitor their fluids and replace any fluids that they're losing. Check their neurological status at least every 2 hours, monitor their vital signs, and then also assess their mucous membrane. So our assessment, these patients are going to have symptoms of dehydration. So kind of pause your video here and just think about what kind of symptoms we see with dehydration. They're going to have an increase in urination, like I said, up to 20 liters a day. They're going to have an excessive thirst. You want to replace this fluid loss. You want to use hypertonic salines. You'll also have a diluted urine with a low specific gravity, less again than 1.005. Your first real step for diagnosing this is to do an INO for about 24 hours. And if you've got urine output more than 4 liters during this period, and it's greater than the volume the patient has taken in, then you can pretty much start thinking diabetes insipidus. And again, realize that these patients have anywhere from 4 liters to 30 liters a day. Your urine osmolarity is going to be anywhere from 50 to 200. So how are we going to treat this? Oral chloropropamide, desmopressin acetate is your DDAVP, and it is the preferred intervention, and these patients will more than likely be on this for life. Early detection of the dehydration, maintain adequate hydration. So since these patients are urinating so much, you want to make sure they have plenty of fluids at bedside. And then teach these patients to weigh themselves daily to identify weight gain. Any weight gain of 2.2 pounds or more, you should be looking at, start looking at fluid overload. So on to syndrome of ineffective antidiuretic hormone. So SIADH and DI have a lot of the same signs and symptoms, but we're going to go over those, and I'll put you a couple of charts on here to kind of help tell you the difference. So on SIADH, this can lead to a medical emergency. You have vasopressin that's secreted even when your plasma osmolarity is low or normal. Your normal feedback mechanisms, they're not functioning properly. And you have water being retained in SIADH. So the water being retained results in hyponatremia because all the water is retained, the urine gets dilute. So things that we'll see with SIADH are you can have a recent head trauma or a recent CVA, tuberculosis or other pulmonary disease processes, cancer. We see this a lot in our cancer patients. You want to look at all their past and current drug use, and then of course a decrease in those serum sodium levels. The kidneys will start holding on to their renin and their aldosterone, so that helps to increase the urine sodium loss and leads to greater hyponatremia. So then again, you have water retention, hyponatremia, and then you start having fluid shifts of your different electrolytes. Your vital sign changes can include a full inbounding pulse, hypothermia because of the CNS disturbances, water retention, we've already said that, and then let's go to the next slide. So interventions for SIADH, you're going to do fluid restriction, and a lot of times this fluid restriction is like 500 to 600 milliliters a day, so it's a strict fluid retention. Drug therapy, you're going to put them on diuretics, a hypertonic saline solution, and declocycline. Monitor for fluid overload. Put these patients in a safe environment because they are having CNS changes. They need to be safe, and then of course be doing a neurological assessment every couple of hours. Also remember why we are doing such a strict fluid restriction, because the more they take in, the more it dilutes that sodium, further retention, and further hyponatremia. The declamycin is an antibiotic, but it can help correct the fluid and electrolyte balance. And then your hypertonic saline that you'll be using is your 3% sodium chloride. So here is my little picture that shows your SIADH. Remember that it is a water problem, but it's decreased output. So you have tachycardia, bounding pulses, hypertension, decreased hemoglobin, decreased urine output, weight gain, decreased hematocrit and sodium. And then your diabetes insipidus, remember the Sipsey River, you're going down the river, so you have a lot of urine output. But you have weak pulses because you're having all of this output and you get weak. You have increased sodium, hypertension, dry mucous membranes, increased hemoglobin, dry skin, increased hematocrit, and then they're really, really irritable. So hopefully this picture will help you remember this a little bit better. And then I also gave you this one because I just thought it was funny. Your SIADH stops the PP. It's caused by brain tumors, trauma, and bad bugs. A complication might be SIADH, low output sodium, gained weight, and high specific gravity. And then your diabetes insipidus is the opposite. You'll see PP give IVs, PP give IVs, PP give IVs. So hopefully these will help you remember these two a little bit better. So adrenal gland hypofunction. Adrenal corticosteroids may decrease from inadequate secretion of ACTH, so we have hormones that are not functioning properly. You have a dysfunction of the hypothalamic pituitary control mechanism. So adrenal gland hypofunction occurs basically because of the lack of ACTH. And it can also be brought on by a life-threatening crisis or stress. It can appear without warning. You can have a lack of steroids, which can cause problems, and then decreased cortisol levels result in poor glucose regulation, so then you get very, very low blood glucose levels. Your kidneys are not filtering like they need to. You can have an increased gastric acid production, so they're at risk for GERD, and it can cause anorexia and weight loss. So Addison's disease is part of this. You can have your primary or your secondary Addison's disease. There are tables on page 1274 which has the causes of primary and secondary adrenal insufficiency, which are things like autoimmune diseases, tuberculosis, AIDS, hemorrhage, pituitary tumors, postpartum pituitary, and then also it has adrenal insufficiencies, the signs and symptoms over here. So if y'all just look on page 1274 for this particular information, it also gives you care of the patient, which is basically when a patient is in the Addison crisis part of this, which you're going to be doing a rapid infusion of normal saline. You're going to give them steroids and a lot of steroids. These patients are going to have high potassium levels, so you're going to be administering insulin and then administering things like KXLate, giving loop diuretics, which is Lasix, monitoring I&O, monitoring their heart rhythm, because we all know that increased potassium can affect our heart. And then we're just going to be monitoring, everything from that point on. With Addison's disease, you're going to see problems again, such as anorexia, nausea, vomiting, diarrhea, and abdominal pain. You need to ask about weight loss. Women may be having menstrual changes related to that weight loss. And then look, again, check their blood sugar, because they're not going to be able to regulate it like normal. They can either end up being hyperglycemic or hypoglycemic. It just depends on the ACTH. And then depending upon their CNS status, how lethargic or depressed they are, we'll be, treating that and monitoring that as well. So this goes over the signs and symptoms for Addison's disease for you. They can have some bronze pigmentation of the skin, and these are just really, these patients almost look gold. Hyperglycemic, postural hypertension, GI disturbances, weakness, weight loss. The adrenal crisis is where we fall into the crisis part, the Addisonian crisis. That's when they have profound fatigue, dehydration, vascular collapse. They have decreased sodium and increased potassium. And then I just have another picture over here that goes over the rest of the side effects. We just talked about this. The Addisonian crisis is a life-threatening event. These patients need cortisol and aldosterone, and their bodies just don't have the available supply, and this usually occurs from a stressful event. So adrenal gland hyperfunction, this is when we start talking about Cushing's syndrome and disease. So our hypofunction is Addison's, and then our Cushing's syndrome is hyperfunction. This can be caused by so they're having a lot of cortisol or a lot of androgen production with the adrenal gland hyperfunction. Cushing's disease is caused by an increase of cortisol and excess of cortisol in the pituitary gland, or a problem in the hypothalamus. And also patients who are on long-term steroids can also lead to the excess of cortisol, as well as an excess of if they've had a recent stress or trauma. The high levels of steroids can kill these patients' lymphocytes, which help them to fight infections. It also shrinks organs that contain lymphocytes, such as the spleen and the lymph nodes. So you have white blood cell production that's decreased. So basically all of these changes reduce the protection that your inflammatory and your immune responses. So all those white cells that you normally have to fight infection, you don't have as many as you normally would have. So our assessment, you're going to have skin changes, cardiac changes, musculoskeletal changes, glucose metabolism, immune changes, psychosocial assessment that we want to see with these. The most common cause of Cushing's disease is a pituitary adenoma, and we've already said the pituitary adenomas are normally benign tumors. Men are more likely to develop Cushing's disease than men. And we just, of course, want to do a complete history for these specific patients. These patients have so many changes at this time because of the excess in cortisol. They can report weight gain, and increased appetite, sleep pattern, fatigue, muscle weakness. Women can stop menstruating. They have a lot of ulcer formations from the increased hydrochloric acid, and then they have a decreased production of the gastric mucus. So Cushing's disease is a lot worse than Cushing's syndrome, but I'm focusing more on Cushing's syndrome because this is what you will see more of. If they have personality changes because of the CNS changes, you'll see a moon face. Moon face is characteristic of Cushing's disease. There, of course, increased susceptibility to infection because of the decrease in lymphocytes. Males get gynecomastia, which is where they actually start developing large breasts. They have fat deposits on the back. They're at more increased risk for osteoporosis because of bone changes. They can get bruises and petechiae, and also the purple striae that you see on this man's left leg is characteristic. They have thin skin. Women have amenorrhea and hirsutism, which is where they are developing facial hair. Of course, increased acid leads to GI distress, thin extremities. They're retaining sodium in fluid, CNS irritability, and hyperglycemia. So basically what you see is what we call a truncle. They have these big trunks, and then their extremities, their arms and legs, are extremely thin. So how are we going to manage this? We, of course, want to make sure these patients are in a safe environment. With the hyperkalemia and some other issues, these patients are more at risk for seizures. And with the skin changes and everything, that's the reason why they have the bruises and the thin skin. They can have acne, cardiac changes, which we've already said. They can have nitrogen depletions. So, we'll be monitoring all of these and replacing the things that need to be replaced. Drug therapy for this specific disease. The newest drug for hypercortisolism is called Signifor, and you don't really have to know anything about it. Just know it's the drug for Cushing's disease. It is a subcutaneous drug. As far as nutrition therapy, these patients are going to have fluid and sodium restrictions. We're going to be having like no added salt diets, limiting them to about 2 grams a day, monitoring I&O, monitoring their weight. Remember again that rapid weight is the best indicator for fluid retention and overload. And then sometimes radiation therapy is used to treat this, but it's not always effective, and it does help destroy the normal tissue. And then we're just going to monitor with our lab results. We'll check all of our lab results, especially our cortisol levels, ACTH, and realize that all of your lab levels are going to be elevated, especially your cortisol levels. Your ACTH levels can vary. They can either be high or low with this disease. The surgical management is a hyphosectomy and adrenalectomy, and you don't have to know very much about them, except that those are the surgical procedures for these. So change slides. So hyperaldosteronism is an increased secretion of your aldosterone. It results in a mineralocorticoid steroid excess. The Conn syndrome results in excess of aldosterone from one or both of the adrenal glands. Conn's disease results from excessive secretion of the aldosterone from one or both of your adrenal glands, usually caused by an adrenal adenoma. You have increased aldosterone levels that can cause disturbances in your fluid and electrolyte balance, and then that triggers the kidneys to retain sodium and then excrete your potassium and hydrogen ions. So then you have hypernatremia, hypokalemia, and metabolic alkalosis. The sodium retention can cause an increase in your blood volume, that raises your blood pressure, and then of course that increases your risk for strokes, heart attacks, and kidney damage. So the primary symptoms you see are your hypokalemia and elevated blood pressure. Those are the most common problems. They can have headaches, fatigue, muscle weakness, dehydration, and have a loss of stamina. Paresthesias can occur. Again, that's the sensations of numbness and tingling. It's diagnosed with laboratory studies, x-rays, and CT or MRI. Your renin levels are low, your aldosterone levels are high. So the interventions are to do an adrenalectomy, which is the most common treatment for this. You may have one or both adrenal glands that are removed, but realize that the potassium levels have to be stable and normal before this surgery can be performed. Drugs that are used to help increase your potassium levels are a spironolactone, which is also called aldactone, and the patient can also be put on potassium supplements itself. Pheochromatoma is a catecholamine-producing tumors arise in the adrenal medulla. The tumors produce, store, release epinephrine and norepinephrine. This tumor can be anywhere from the neck to the pelvis. These patients have a lot of intermittent hypertension. It can last several minutes to several hours. It can be precipitated by abdominal pressure, things like the Valsalva maneuver, or palpating on the abdomen, have an increased heart rate, nausea and vomiting, weight loss, hyperglycemia, diaphoresis, pallor, weakness, visual disturbances, pain, tremor, and nervousness. To diagnosis, we're going to do a histamine test. The causes a rise in the blood pressure. We don't see this test a lot. Nursing management is to avoid physical and emotional stress, monitor the blood pressure in sitting and lying, frequent bathing to avoid chilling, and then administer analgesics for pain and sedatives for rest and relaxation. You want to increase the calorie, vitamin, and mineral intake because of the increased metabolic demand. Avoid, of course, caffeine and coffees, teas, colas. Limit activity during the blood pressure problems, and administer a Preslin for hypertensive crisis. And again, just help these patients with their self-care, allow time to verbalize concerns, and recruit help if you need it from other healthcare people. So that is a wrap. Hope you liked my video. Bye.